Modern-day contact lenses have become more breathable, wettable, and disposable. They're also proven to be healthier. In a 2005 Australian study, patients wearing daily disposables were less likely to develop corneal ulcers versus their extended-wear silicone hydrogel counterparts at 7.5% versus extended-wear at 9.3%. While daily disposables are increasing in popularity, up 3% from last year, 70% of contact lens patients are not wearing daily disposables. Regardless of the soft lens modality, most of our present-day contact lens complications are secondary to inflammation and are often preventable if you look closely. Giant papillary conjunctivitis, or GPC, is an inflammatory reaction of the palpebral conjunctiva that can be induced from not only debris on the lens, but also due to mechanical irritation from the lens itself. Patients may complain of discharge or decreased wear time. We should be flipping the upper eyelids on our contact lens patients at every visit to intervene as soon as signs present. Contact lens-induced acute red eye is strongly associated with hydrogel extended-wear lenses, with a yearly incidence rate between 4 and 30%. Claire typically presents as an acute red eye with conjunctival and circumlimbal hyperemia. This inflammatory reaction most often occurs in the first 3 months of lens wear. Strong evidence points to endotoxins released from bacteria on hydrogel lenses or from the solutions as the culprit. Almost always, Claire is associated with sleeping in contact lenses. Under hypoxic conditions, such as wearing a contact lens which acts as a barrier to oxygen, the cornea becomes edematous. This attracts inflammation in the form of white blood cells, and subepithelial infiltrates are aggregated towards the cornea. They can be caused by a host of different things, from the lens to the solutions to idiopathic causes. Depending on the severity, they can cause severe or mild discomfort. Superficial punctate staining typically requires you to look beyond the contact lens for the culprit. What solution is the patient using? Do they have a healthy tear film to support the contact lens? A 2010 study found that corneal staining was not associated with developing infiltrates secondary to extended wear. In fact, it was discovered that SPK developed due to the bacterial bioburden on the contact lenses. For all these conditions, our goal is to decrease inflammation and eliminate the root cause, if at all possible. We start with a strong steroid to decrease the inflammatory response. Additionally, we like to move as many of our patients to single-use lenses in order to reduce any problems that overwear or solutions might cause. If a patient must be in a long-term replacement lens, then we switch them to a peroxide solution. In cases of GPC, we also might utilize an antihistamine mast cell stabilizer to decrease any allergic component. Although we cannot cover every inflammatory reaction to contact lenses in this episode, these conditions and studies support the importance of not approaching contact lens fits as a one-lens-fits-all mindset. An international 2010 study revealed that discomfort is still the #1 cause for contact lens dropout at 50%. Inflammatory reactions secondary to lenses are a direct culprit, and they are typically preventable. Let's stop dropout before discomfort starts and be on the lookout for signs of ocular inflammation, and ultimately improve our patients' quality of life.